We have some submitted questions from audience. Um, okay, so let me go to the first question. Can you talk about how do the safety profiles of these agents compare with those achieved by CAR T-cell therapies? Martin, maybe you could try to address that since we don't really have a CAR T-cell approved for CLL at this point in time, but mantle cell certainly you do.
Well, it's fair to say there's a huge difference. I mean, knowing that CAR T cells are much better tolerated than, let's say, autologous transplant, of course we know it has toxicity, and specifically for the Brexy, the registered CAR T cell product in mantle cell lymphoma, we do see huge neurology side effects, and therefore, despite the fact that, for example, in our institution, the first patient, in fact, was age 74. It's fair to say that was a fit 74-year-old lady. And we are talking about the general population, which is, their toxicities play a much higher role. So if you ask me, what is the comparison between the non-covalent BTK inhibitor and the CAR T cells? I would really say, and normally I'm cautious with these words, it's like black and white. It's like day and night, and really a huge difference. So these are two totally different groups of patients. And I assume the same for CLL.
Agree. Next question, we'll go to Debbie. This is a question. Is there any patient baseline characteristic that would lead to avoidance of a BTKI? You wrote the paper on intolerance, the review in blood. Maybe you can comment specifically on the covalent inhibitors.
That's a great question. And I think really there's a lot of management that can go into these patients, that there's not really a set patient that can't receive a BTK inhibitor. Just because a lot of the side effects that we, have been worried about in the past, for example, atrial fibrillation, I still put patients on BTK inhibitors that have a history of atrial fibrillation, even if they're on anticoagulation. As long as you don't use warfarin in combination with these BTK inhibitors and monitor carefully for bleeding risk, they really, I've given a lot of patients this regimen. You have to be careful with atrial fibrillation just because there are some cardiac medications like carvedilol that can have some interactions with the BTK inhibitors. So you just have to have a good pharmacist reviewing your concomitant medications. And, there is now, at least in the United States, there's a new procedure called a Watchman procedure that's done that actually can block off the left atrial appendage. And that procedure, about 45 days after, they go in and they look, and if there's no leak to this block, then they can stop all anticoagulation. And so that kind of limits that bleeding risk too. And so really, there are patients, who, if they don't have other options, I think most patients can get a BTK inhibitor. Those with cardiac risk, if they haven't had venetoclax therapy yet, are likely a good candidate for venetoclax first. But, in the end, most things are pretty manageable with BTK, even the first generation ones. And so these, the further and further we get along, it's really becomes a lot easier to manage any of these comorbidities.
Thank you. Next question is, when they say they, I'm assuming the drugs that we presented today have the potential for first-line therapy, and maybe I can answer pirtobrutinib, Debbie, you can answer the drug, and then Martin, you can answer pirtobrutinib for mantle cell. Why don't we start with mantle cell? Do you see this drug having the potential for frontline or any BTK inhibitor? I don't think any of them are approved in mantle cell as a frontline therapy, are they?
Well, they soon going to be registered, it's fair to say. So there's a first wave of studies investigating combinations with chemo in a randomized way. And one of them, the SHINE trial, comparing BR plus minus ibrutinib, will be published very soon, I would guess, in the first quarter of next year. And we have this ongoing study in younger patients, the triangle trial, where we substitute autologous by ibrutinib. And I guess these data will be available either end of this next year or the year thereafter. So this is, I think, already prime time for combinations. This is going to happen very soon in 2022. Now, the next study of or wave of studies already going on, which is a head-to-head comparison, and these studies will potentially establish BTK inhibitors in the first line. So this is not a vision or a fantasy, but this is gonna happen next year. And therefore, for conventional covalent BTK, this is present or near presence. And I think based on its better tolerability, just to remind that, you had to stop covalent BTK inhibitors in real life scenarios between, 40 to even higher rates because of toxicities. So I think with this compound, better tolerated and potentially more efficient, that has still to be proven in this randomized trial, yes, definitely.
Debbie?
Yeah, the MK-1026 drug, I think, definitely has potential in first-line therapy, just secondary to its, great efficacy and good side effect profile, and is planning some combination frontline studies in the future. I think, we're still a ways off for this in frontline.
Yeah, I would give a similar answer for pirtobrutinib. Certainly has to have a positive trial in the frontline setting, but they are doing head-to-head versus ibrutinib and a comparison against chemoimmunotherapy. I think it's bendamustine rituximab, if I'm not mistaken. So I think that, depending on results, it offers great opportunity to move to earlier lines of therapy. Along those lines, based on the data that we have, another question being asked is, how would pirtobrutinib or MK-1026 fit into the current landscape? I could answer that first. For pirtobrutinib in CLL, it's a relapse refractory study. And so largely we're gathering information about pirtobrutinib following covalent BTK inhibitors, and to a certain extent following venetoclax and a covalent BTK inhibitor. And so based on the excellent data and the tolerability profile, from a sequencing perspective, you can imagine a patient starting with a covalent BTK inhibitor, then sequencing to pirtobrutinib, or being the double exposed patient population, and then sequencing to pirtobrutinib. I think the million-dollar question that we're still trying to sort out in the relapse refractory setting is, for example, should this be the first BTK inhibitor prior to a covalent BTK inhibitor? And certain studies that are ongoing now will help to address that question. Debbie, would you want to comment on the MK-1026?
Yeah, I would say similarly right now, all the data are in relapsed disease. And so it depends on what strategy you want to take. If a patient had a frontline, covalent BTK inhibitor, it would be reasonable to switch over to this, or, wait until they've already had venetoclax therapy. And, now when we see these double refractory patients, there's a lot of clinical trials to choose from, and it might just depend on the patient. Because of course, CAR T trials are in clinical trial for CLL right now, and maybe a healthier, younger patient might be a better candidate for CAR T. Obviously noting the difference in toxicities, but I think these patients are going to have a lot of option as all these different modalities of therapy come through in these relapsed clinical trials.
Next question is about mantle cell lymphoma. Martin, can you speak to the results for mantle cell lymphoma, PIRTO, in patients that discontinued covalent BTK inhibitors due to progression, as opposed to those who discontinued due to intolerance?
I think this is a really critical question, and I have to admit I don't know the answer, because these data were not split up so far, but at least Michael Wong promised me to include that in the definite full manuscript. But it's fair to say, and that's obvious, also holds up for CLL, patients stopping a covalent BTK inhibitor because of toxicity, they of course in general have a better outcome in comparison to the ones who are progressing under BTK inhibitors.
Thank you so much. Well, this has really been exciting. This ASH meeting was a great meeting in that I think we got to see more maturing data for patients who are receiving the non-covalent BTK inhibitors. I would ask both you guys, where do you, in the space of the non-covalent BTK inhibitors, where do you see the data gaps at the moment? What would you like to see in order to help really further develop this area?
I can answer that question first. I think what is also going to be interesting when these patients relapse on these drugs to see what types of resistance mutations are developed, because there's a risk of these gatekeeper mutations that are going to prevent any further response to any BTK inhibitor therapy. And so I think that will be interesting, especially as we move these compounds towards the frontline therapy, what we expect later on down the road.
I fully agree with that. Martin?
That's a cool idea. I didn't thought that through, but it might well be that, the opposite order or sequence of these two approaches might be much more beneficial. Agreed. In addition, I think based on the favorable tolerability, I would love to see the results of the randomized comparison. Of course, we're not yet there, but based on that one, I think this compound is especially prone for potential combinations. And especially in mantle cell lymphoma, which is maybe the bad older brother of CLL, if you want so, we tend to combinations right away, and there I really see some advantage.
Martin, I want to ask you another question for mantle cell. If we had access to pirtobrutinib and access to venetoclax for patients with relapse refractory disease, how would you decide which to use based on current data?
That's an easy question, because venetoclax alone as a monotherapy does not achieve ongoing remissions. So therefore, I would not go for venetoclax mono or just to bridge to subsequent treatment. So if I have a patient who is not qualifying for CAR T cells, clearly been said, pirto would be my favorite. The other thing is when it comes to combination, and there we do have the combinations of venetoclax plus ibrutinib, and that anyway would be probably the preferred approach in mantle cell lymphoma.
Debbie, one other question. The general teaching, at least that I've heard, is at the moment, allo transplant should be considered for people who have had at least 2 targeted therapies, maybe with an inadequate response to the second agent. Do you think the MK data or the pirtobrutinib data changes that, and that for most patients, they should be onto their 3rd targeted therapy before we're thinking about transplant?
I think this is a great question that I don't know we fully know the answer to. A lot of times patients are going to self-select because, obviously with a median age of diagnosis in the 70s with CLL, there's, already, a lot of patients who aren't going to qualify for allogeneic stem cell transplant. So these 3rd generation BTK inhibitors are great for this population. I think the younger patients, this is where it becomes, a big question, because I still do think that these patients are really high risk. And, I really thought a couple of years ago, maybe I would never recommend an allogeneic transplant to a CLL patient, but now, I'm kind of coming around to the idea that there are some patients that I think that this is really the only option to really get them in a long, durable remission and potentially to cure them.
Okay, 1 minute or less for either of you guys. First question, Debbie. For patients in your program who are now being treated with non-covalents and they progress, do you have a preferred mechanism of action that you think is going to be the best fit for post-covalent, non-covalent BTKI?
I'm pretty excited about the CAR T data. If you can get somebody back into remission, we just mentioned allogeneic stem cell transplant. I have a new drug that I'm working with. It's a PKC beta inhibitor, so just a little bit further down the BTK or the BCR pathway, which is looking really promising in these patients too.
And then Martin, last question. A year from now or 2 years from now, is there any role for auto transplant in mantle cell, or is it all about CAR and targeted therapies?
Well, that's a good question. This is my hope. However, we know the experience in multiple myeloma, or whether they try to overcome autologous transplant since 10 years or so, or even more. And so far, autologous is still standard of care in younger patients. Knowing that, I mean, there are only few diseases where this is really, let's say, last man standing. So on the long range, I absolutely agree. Autologous transplant will become less and less more important. Therefore, I'm looking forward also to the results of the American trial comparing plus minus autologous and MRD negative patients.
All right, well, thank you very much. That was a great discussion. I'm going to now move my slides forward. Please remember to complete the evaluation form to claim your CME credits by clicking on Evaluation tab below. An on-demand recording of this session will be available on the Springer IME website in the next couple of weeks. On behalf of myself, Dr. Stevens, Dr. Dreiling, I think we all want to thank you guys for participating in our presentation today. Great questions, and thanks so much.